We're just getting ready to get started here, so if you guys can take your seats. Hi, everybody. Thank you so much. So welcome, everyone, to Russell Sage College's 13th Annual Nutrition Lecture, sponsored by CDPHP. As you all know, we're here to talk about menopause today, so it's a hot topic, and glad to see you all here. My name is Lara Bryn. Oop, hitting my microphone. My name is Lara Bryn. I am the anchor at Channel 6. I anchor the noon and the 5 o'clock. But I also do the health reporting at Channel 6. So I'm happy to be here and be a part of this event today. So first I'm just going to ask you all to silence your cell phones so that we don't hear buzzing and fun, interesting music while we're in the middle of talking about hormones. I also want to give a shout out to all the people on the live stream that are tuning in. Thank you guys as well. And a reminder that CPEU certificates will be emailed to all registered attendees once approval has been granted. So just a heads up about that. And at this time, I think we'll get started. I'd like to introduce Dr. Matthew Shaftel, the 11th president of Russell Sage College, to share some welcome remarks with you all.
Well, good afternoon, and thank you all for joining us today. I'm really thrilled that we are, as always, a little bit ahead of the curve and finally dealing with an issue that is so important to women's health. And I want to start by thanking our nutrition department for being so forward-thinking in this moment and really supporting our community in such an important way. So everybody from the nutrition department, will you just please rise? And I want to give you a round of applause. Thank you so much. And of course, I need to thank our sponsors, CDPHP. We're going to hear from them in just a moment. But again, our partnership with you and the way we serve our community together is so strong. And I'm grateful for your support for this and also for our Thrive Initiative. And as you know, our Thrive Initiative supports the 8 points of well-being and health, and is such an important part of who we are as a college. So thank you again, CDPHP, for helping us to be distinctive and to really focus on health rather than just focusing on the training of students. We have to be holistic in the approach that we have to everyone. And speaking of partnerships, oh, thank you. Speaking of partnerships, I'd like to thank my colleague Toyin Tafati, president of ACPHS, who has joined us here today to say hello. And Toyin, thank you. As you all heard yesterday, we announced a merger with ACPHS, and it's a really important opportunity for us to really grow the impact of health education in our region and to become the largest institution for healthcare support in the region. So we're very excited about that. So it is now my privilege to ask Sonia Hauser, chair of the Russell Sage College Nutritional Department, to present this year's Preceptor of the Year awardee.
All right, welcome everyone. So I would like to congratulate our 2025 Preceptor of the Year Award recipient, Bonnie Daly. Bonnie, come on up. Bonnie is a lead clinical dietitian at St. Peter's Health Partners and someone who absolutely goes above and beyond, believe me, for our students. And we're so grateful for her ongoing support and dedication to mentoring our students. So Bonnie, can you come forward? You don't have to speak, it's okay. Come on up this way. We can go right here and take a picture. Congratulations. I love that we kept it a surprise.
It's very much a surprise.
Thank you. Oh. All right. Laura, on to you.
All right, thank you, Sonia. Cassie Diorio joined CDPHP in 2016 and currently serves as marketing manager. Prior to joining CDPHP, she contributed to public health initiatives at both the local and state levels, including a CDC-funded grant focused on increasing breastfeeding rates and the development of a perinatal hepatitis B prevention policy implemented across New York State hospitals. In her current role, Cassie leads member-focused, data-driven marketing strategies designed to boost engagement with CDPHP products and services. Throughout her tenure at CDPHP, she's led and supported various population health initiatives, most notably those aimed at advancing maternal and child health and improving birth outcomes in the community. Cassie's a dedicated advocate for women's health and holds a Bachelor of Science from the University at Albany, a Master of Public Health from the University at Albany School of Public Health, a certificate of graduate study in maternal and child health, and is a certified lactation counselor. So it's now my pleasure to call up Cassie Diorio to share a few words.
Thank you so much for that warm welcome, and good afternoon, everyone. I am thrilled to be here today representing CDPHP and look forward to the important conversations ahead. At CDPHP, we consider ourselves to be the health plan for women and families. That means through every stage of life, we're by your side. In 2022, we joined forces with Ovia Health after recognizing how equally committed their team is to improving the health of women, families, and babies, and have been working together closely ever since. Ovia is a robust app-based platform that offers support across the entire health journey, from cycle tracking and conception to pregnancy and parenting, and to today's focus, menopause. With the help of the Ovia apps, CDPHP members now have no-cost access to personalized, comprehensive support during some of life's most vulnerable moments, all at their fingertips. I am so proud that we are joined here today by Ovia's Chief Product Officer, Dr. Leslie Saltzman, as a result of this incredible partnership. As today's keynote speaker, Dr. Saltzman will provide an overview of the pathophysiology, symptoms, and treatment of menopause. Menopause is a major life transition and a topic that is finally getting the attention it deserves in the world of women's health. This afternoon, Dr. Saltzman will discuss how menopause impacts overall health, including cardiovascular and bone health. She'll also share insights for managing symptoms and promoting well-being during this important period of life. Whether you're currently managing symptoms related to menopause or just looking to better understand your reproductive health, I highly encourage you to download the Ovia app and see all that it has to offer. Thank you for attending, and I hope you enjoy today's presentations.
Thank you, Cassie. And now it's my pleasure to introduce our speaker, Dr. Leslie Saltzman. Dr. Saltzman serves as the Chief Product Officer at Ovia Health, a LabCorp subsidiary and a leading digital platform for women's and family health. She's also the Medical Discipline Director for Consumer Health at LabCorp. And with more than 15 years of experience in clinical and business technology, Dr. Saltzman brings a wealth of expertise to her roles. Previously, she was Ovia Health's Chief Medical Officer, where she led the clinical team, overseeing research and studies to guide business strategies and ensure evidence-based solutions. A board-certified physician specializing in internal medicine, Dr. Saltzman continues to practice medicine. Her career began with founding a primary care practice exclusively for women, integrating internal medicine, gynecology, psychology, and nutrition. Beyond her clinical work, she's held leadership roles in early-stage health technology companies, leveraging clinical data to create innovative products that enhance patient care and support clinical research. And now I'll turn the program over to our keynote speaker, Dr. Saltzman.
Well, I didn't need help before, but maybe I do need help now. I just want it on the big, no notes.
That's not possible. So it's big there.
It is, I asked before.
No, it's not.
Okay, thank you so much for having me. This will be fine. So before I start, I just wanted to say that I'm really happy to see everyone gathered here together today, because this is a topic that impacts almost all of us. If it doesn't impact you personally, it impacts someone you know. All of us, assuming we're going to live that long, are going to experience menopause. And as life expectancy for women continues to increase, it's a period in life that represents like a third to up to 50% of your life. And so I think it's really important that we learn about it and we destigmatize it and realize that it's something that just as we spend so much time, teaching kids about the changes that they go through in puberty, that we actually address what happens as people age. So in terms of today, this isn't really a formal academic lecture that is supposed to, you're supposed to be taking notes about menopause, but much more the kind of conversation that I have with my own patients when I'm talking to them about menopause and their symptoms, because I think that is what is missing for so many people. So I'm going to talk through kind of what happens during menopause, the symptoms that people experience, the treatment, but I'm really going to focus on the medical treatments and spend a lot of time talking about menopausal hormonal replacement therapy, because I think that's where there's so much questions and misconceptions and also unanswered questions that we all have, and then share a little bit about what you can do or resources. And so in terms of menopause, I first want to just start with some definitions. Menopause, in many ways, could be thought about as both a single point in time, a single day, as well as then the period after you go through menopause, like postmenopause. And so menopause is characterized by the 1-year anniversary of your last menstrual period, and the time leading up to it, when you start to have symptoms, that is what we call perimenopause, or the menopausal transition. And perimenopause, we actually consider it the 1 year also after after menopause. And for the average person, it's 4 to 7 years in perimenopause, but it can be up to 10 years. So it can be a very long period in time. And then in terms of symptoms start in perimenopause, but continue afterwards. So some people experience symptoms for 15 years or even longer. In the US, the average age of menopause is 51. We see kind of variations around the world, 48 in South America, 52 in Europe. A lot of this we think is due to genetics. If people have mothers or sisters that went into menopause earlier or later, they are about 50% likely to experience the same kind of thing. There's also some other things. Smoking, we think, causes people to go into menopause earlier. Having a child late in life seems to cause menopause to start later, and a whole bunch of other things that honestly we don't have real clear correlation in terms of what happens with when you're going to experience menopause. When I'm talking about this in general, I'm talking about what we call natural menopause, as opposed to the menopause that can occur based on whether you go into surgical menopause, and that would be if you have a hysterectomy or if you have your ovaries removed, or a medical cause of menopause, such as if you're undergoing chemotherapy or radiation to your ovaries or your uterus in general, and that can cause another type of menopause that's very sudden. And otherwise, there's other things that can happen too. What I'm talking about here is on average, but some people start menopause early, and that could be early menopause, which is when people experience menopause between 40 and 45, or premature menopause, which we think is related to kind of premature ovarian failure, or basically your ovaries kind of aging quicker than expected, and that is when menopause happens before 40. In terms of the stages of menopause, it sounds kind of crazy to think, but there actually wasn't even a medical framework for what happens during menopause until 2001. And that's when this model was developed, which is called the straw model, which is the stages of reproductive aging workshop that came together to devise this model that basically divided up the stages of menopause. The group met again in 2011 and basically added many more details that you actually see here, which basically explain some of the hormonal changes that are happening during menopause and then what is happening in terms of symptoms. And so what you see is that as a person goes through their reproductive lifespan, as they get towards like the end of their reproductive lifespan, meaning when you can kind of achieve pregnancy, you basically are already starting to have some of these chemical and hormonal changes that are happening, which basically lead to subtle changes in the menstrual cycle. And so what people start to notice is that their periods can become lighter or heavier. They start to notice some minor irregularities in terms of the cycle length or the time between cycles. And then as they go through and start into perimenopause, those changes can become more pronounced and more frequent. And so what we see in perimenopause, and what a lot of people come to me complaining about, is that they always had regular periods and now they're skipping periods, or their cycle is now 35 days when it used to be 28. And then what we see is, like, as you get towards, your final menstrual period, it's often marked by people are having, periods very infrequently. So it can be every couple of months. Oftentimes women, you think about the right age, they're 48, they're 49, and they come in and they say, I think I'm in menopause, I haven't had a period for 6 months, and then the next month they have another menstrual period, and that clock starts all over again. They have to wait another 12 months. One of the things, this slide may be hard to read the details, but if you look at the details on this slide, it shows some of the changes in some of the hormones that like follicle stimulating hormone, luteinizing hormone, estradiol. But the thing about it is the hormonal changes that we can measure, they're not consistent. And so what it means is that this is also why we don't usually use lab data to make the diagnosis of menopause. And then one thing that you'll notice here is this slide talks about one of the most common things that people notice is when they're having hot flashes and night sweats. Those are called the vasomotor symptoms of menopause. They start in perimenopause and continue afterwards, and that typically they're the most intense in that early part of menopause. And then you'll notice all the way at the end, you'll see another symptom that is on here, which is called the genourinary symptoms of menopause, and that is like vaginal dryness, pain with intercourse. And it's basically the changes that happen to the vagina and the urinary structures that help actually support the bladder, and that the loss of estrogen caused changes in those tissues. And we see those like a couple of years after menopause is when they're the most intense. Now, in terms of why do we go into menopause? I mean, it's pretty simple in the sense that women are born with a finite number of eggs, and as you go through your menstrual cycles, you basically ovulate your eggs, and you get to a point in time when there's very few eggs left, and that the ones that are remaining aren't healthy, and so they don't respond very well to the normal hormonal fluctuations. And because that's happening, what your body does in response is it tries really desperately to get you to ovulate, and so hormones rise higher and drop lower than before. So it's like there's this disruption in the normal hormonal cycling that you have. The other thing that happens is it's not just happening in the ovary. Basically, the feedback mechanisms that happen in your brain are also getting disrupted. And there's also aging that's happening in your brain that also affects the hormone production. And so it's this kind of cycle together of things happening in the brain and the ovary that causes basically the final end of ovulation and then, of course, menstruation. So as I was saying before, when you think about the hormonal patterns, assuming that you're, ovulating and having relatively regular menstrual cycles before menopause, before menopause, you basically have regular cycling. And so if you mapped out what those hormones look like, they're pretty consistent over time. And then what you see in the middle is what is happening in perimenopause, where you see these really extreme fluctuations. And those extreme fluctuations are what causes the irregular symptoms, meaning people can experience, for example, hot flashes and night sweats, and they can have it for a month, 2 months, 3 months, and then they go away, and then they start up again. Or if you can imagine, these hormones are also impacting your brain, so this is why you can also have like mood changes that come and go. And then what you see is, as you go into menopause, you have this rapid drop, primarily of estrogen, and then things even out, so you don't have any fluctuations, which also explains, like, as you transition through menopause and your body's adjusts to it, you don't continue to have the same kind of symptoms as you did before, at least for most people, I should say. Now, in terms of making a diagnosis, so the things that I was talking about before in terms of the hormonal fluctuations really explain why it is that we don't use labs in general to make a diagnosis of menopause, because we don't have any tests that actually are going to help you make the diagnosis accurately. Because we don't really know if, when we're measuring labs, whether that represents the height or the trough, and so we can't really use the data to help make a decision. Now, there are some cases where you have a person that isn't menstruating. They've had a uterine artery ablation. They have a progesterone-containing IUD, like a Mirena. And for those people, they're on continuous birth control pills and they're not menstruating at all. Now, this oftentimes creates like a kind of a conundrum for us, because we try to decide, are you in menopause? Are you not in menopause? So we can tell people and have them stop, for example, if you're taking a birth control pill, and measure your hormones at a specific date, basically the 3rd day of your cycle. And if you have levels that are high, kind of on more than one reading, it does suggest that you're in that period where either you've already had your last menstrual period or you're in that year leading up to your last menstrual period. And so this can be helpful in certain cases, but in general, all the guidelines say if you're in the right age, and typically we say 45 and above, and you're having symptoms, you're having irregular periods, you're having hot flashes, night sweats, I'll go into what all these other symptoms are, we can usually make a clinical diagnosis and say this looks like perimenopause. The one thing I would say, though, is when you do see your healthcare provider, because the symptoms are so wide-ranging, sometimes, although the test isn't necessary to make the diagnosis of menopause, oftentimes we do order other testing, thyroid, for example, or other things to make sure that something else isn't causing the symptoms that a person might be experiencing. Now, in terms of symptoms, I love this slide that shows this picture that basically you see symptoms from head to toe. And the reason for this is because there's estrogen receptors throughout your entire body. For any of us who have experienced menopause, like you notice, like there's changes in your skin, in your hair, There's probably changes in your vision as well, but there's also one of the most common things that people mention is like changes in their brain, this brain fog where people have difficulty remembering things, of recalling words, difficulty in terms of, and this is where I cannot read this either. And you see, the thing that people mention, hot flashes, night sweats, their sleep gets, people complain of their sleep getting disturbed, of having difficulty staying, not so much falling asleep, but difficulty staying asleep. The most common thing that patients say is they fall asleep fine, but they wake up between 2 and 3 a.m. and are up for 2 hours and then fall back to sleep between, around 5 a.m. and then they're exhausted every single day. And they get into this like terrible cycle, and of course you can imagine that makes you feel awful, but it's also super frustrating. There's also, there's changes in terms of weight gain. The hard part about weight gain is there's what we really see is changes in where you gain weight and increased body fat. So when women are before perimenopause, when they gain weight, they tend to gain weight in a way that we think is, in general, metabolically healthy. So women tend to gain weight in their thighs, their breasts, their buttocks, their hips. And that kind of weight gain actually doesn't tend to raise their cholesterol or to cause changes in blood glucose but in menopause, this changes, and it changes very rapidly. So one of the things people complain about is that they're gaining weight in their midsection where they've never really gained weight before. If you could think of it like this, as the hormones change and estrogen and progesterone levels drop, what happens is that women tend to gain weight in more of the same kind of way that men gain weight. And this has important risk factors associated with it in terms of cardiovascular disease development. There's also a musculoskeletal complaints that people have. And so what we know is that estrogen tends to be anti-inflammatory. And it's anti-inflammatory in terms of your entire body, but this really impacts joints. And so what people complain of is like joint pains when they didn't have them before. We also see that bone density decreases. We see that muscle mass decreases, but it also changes. If you look at the muscle fibers get more fat interwoven within them. So the muscles change, the joints change. It also seems to accelerate in some people osteoarthritis. So if you have arthritis, it's like your arthritis gets worse. We also see that with menopause, women become more likely to get certain types of injuries. So it changes something about the tendons, and you're more likely to get tendinitis, or it changes the capsule of the shoulder, so you're more likely to get adhesive capsulitis of the shoulder. We also see, as I mentioned previously, some of those, the vaginal and genital complaints, so vaginal dryness, pain with intercourse, loss of libido, and then frequent urination can go along with it as well. And so in terms of, the thing that's really interesting though is some of the studies say that more than 35 symptoms have been attributed to menopause. However, the things that are most often talked about are like the hot flashes and the night sweats. If you look at frequency, the memory problems and lack of focus is actually, according to some studies, the #1 symptom that people experience, and then followed by the sleep disturbances that I mentioned. If you notice, like on this study, this was of people who are 50 to 54. The genital symptoms are not occurring as frequently, but I think it's just because it's a younger age group here. Now, one of the things that I think happens with menopause is that for a long time, I think it hasn't been taken seriously. When I go back to that previous slide and you think of like all these symptoms, I think it's easy for people to think that menopause is like a nuisance condition where If you're complaining about your skin is drier and you're having a harder time sleeping, people don't necessarily think of it as something that is causing increased risk for women. But this is the one thing that I think is a really important takeaway, is that as people go through the menopause transition, it's really important to look at their risk factors, because women in general are protected up until menopause in terms of the development of cardiovascular disease. And when I say cardiovascular disease, it's basically a broad umbrella term that consists of heart disease, but it also consists of like all the other blood vessels. So it's heart disease, it's stroke, it's peripheral vascular disease, or what can happen in the arteries that feed your legs. And so what we see with menopause is we see changes in cholesterol. So people who may have had normal or relatively normal cholesterol, you see the total cholesterol rise. You see what we call the good cholesterol, the HDL cholesterol decrease. We see the LDL increase. We also see triglyceride levels increase. If you look at blood sugar, this is when a lot of people get diagnosed with prediabetes and diabetes, because we see insulin resistance happening. We also see changes in the blood vessels, where the vessels tend to stiffen, and so you also see increased rates of high blood pressure or hypertension. And when you put all those risk factors together, and then you combine it with some of the things that are happening as part of aging or changes in lifestyle, it really accounts for why women after menopause catch up with men in terms of the prevalence of cardiovascular disease. So we see basically cardiovascular disease happening about 10 years later on average for women than men, but that this is really the time that's really crucial. We also see, if you look on this slide too, that they talk about the oxidative stress. And this is because, as I mentioned, estrogen is anti-inflammatory. And when you don't have estrogen being anti-inflammatory, plus that weight gain, that people perceive it in the midsection, but it's not the physical weight that we see that's dangerous. It's the body fat that accumulates. That's the visceral fat that accumulates around the organs, like the heart, the kidneys, the pancreas, that basically cause this inflammation inside that basically promotes the development of cardiovascular disease. And it's not just the cardiovascular system we have to worry about, it's also your bone health. And so what we see is the changes in menopause. We see basically the cells, osteoblasts, that build bone, they change in response to decreasing levels of estrogen. So basically the bone that is built after menopause isn't as strong as it was before, but we also see other things happening in conjunction with aging, where vitamin D absorption goes down. People tend to exercise less. And as your body composition changes with menopause and you lose muscle, you have more body fat, that also promotes the development of osteopenia, which is low bone density, and osteoporosis. One of the other things I think that is important here is that when you're thinking about management, the guidelines today recommend screening for osteoporosis at age 65. Remember, I said that the average age of menopause is 51. And so if you think about what happens in those 14 years, if you have risk factors for osteoporosis and you wait 14 years after menopause and you have no treatment, guess what happens? You're going to get diagnosed with osteoporosis, and you've sort of missed the window. In the US, hormones are indicated for the prevention of osteoporosis, but when I talk about when we give hormones and how important the timing is, if you wait till 65, no doctor is going to prescribe you estrogen for osteoporosis. And so what I would tell you to think about is your doctor or your healthcare provider should be screening you at age 50 for risk factors. So when you're in perimenopause, thinking about, do I have risk factors for osteoporosis? And then you should get screened with a DEXA scan then. That is guideline directed. And so in terms of treatment, treatment today is geared towards symptoms. And when we talk about symptoms, the hard part is like in perimenopause, there are so many different things happening. So most people are still menstruating, people are still thinking about preventing pregnancy, but at the same time, you're trying to make a decision about what to do. And so for some people, the right treatment in perimenopause is actually just birth control pills. And particularly if your symptom is that you're having really heavy periods or really bad PMS symptoms. Oftentimes what we do is we just put you on continuous birth control pills, and it actually, because it's overriding that hormonal fluctuation, this works for a lot of people in terms of making their symptoms a lot better, minimizing hot flashes and night sweats, and also preventing pregnancy if they desire that. It also works in the same way as like the menopause specific hormone treatment that I'm going to go on to discuss a little bit more. We also then have treatment that is geared towards the vasomotor symptoms, so the hot flashes and night sweats, and we also have treatment that is geared towards the genital urinary symptoms. That is it. None of the treatments that we have been FDA approved for any of those other 35 reasons for menopause, which I think is really hard for women and really frustrating, because if your complaint is that you have joint pain and you're gaining weight, the current guidelines actually say you're not a candidate for menopausal hormone therapy because you don't have hot flashes and night sweats. And I'll talk about the risk here and and so this is actually the care that a lot of people are getting. They're basically being told, unless you have really severe hot flashes and night sweats, hormone replacement is not appropriate for you. And let me talk a little bit about like what the other things are. So aside from the menopausal hormonal therapy, which you'll often see abbreviated MHT, that includes two different things. One could be estrogen only. Estrogen only is appropriate for people that don't have a uterus, or estrogen progesterone therapy, which is the combination of estrogen and progesterone. We give progesterone in combination because estrogen stimulates the lining of the uterus, and if it's basically left unchecked, it can promote uterine cancer. One thing to note is that in terms of progesterone, if you have an IUD that contains progesterone, like Mirena, that counts as being on progesterone, and many people, me included, think actually that's the best one in terms of the safety. We do have other medications that are approved for the vasomotor symptoms of menopause. One of them is an antidepressant, paroxetine, that's been repurposed. A lot of doctors still will basically say, oh, you have anxiety, you have depression, it's menopause, let me give you like an antidepressant. And it does help with some of the symptoms. The hard part is, when I mentioned earlier, the cardiovascular disease, the weight gain, the inflammation, I sort of wonder, those medications actually have not been studied to see if they make any improvement with those symptoms or those risk factors. And so if you're on a treatment that isn't hormone-based, in many ways it's like you're treating one symptom, but it doesn't treat any of the underlying risk factors that go along with the menopausal transition. And then lastly, there's a new medication that came on the market a couple of years ago. You may have seen the ads for Veoza, which is just for hot flashes and night sweats. The medication, personally, I haven't prescribed it a lot. It now also has a black box warning about some liver risk factors that go along with it. It requires a lot of monitoring. So in terms of menopausal hormone therapy, the benefits here: reduce symptoms. As I talked about, those 35 plus symptoms that people experience, the benefit of hormones is that they tend to treat all of those symptoms. So people notice like their skin is thicker, if their skin is less dry, obviously hot flashes, sleep, like everything across the board. And this is only true really for using the hormonal therapy systemically, meaning you're taking a pill, a patch, a cream. It's not for estrogen that is just used vaginally, because the levels that are used vaginally, except for there is one ring, they just don't get up high enough to basically impact the entire body. But the menopause hormonal therapy, it reduces symptoms, including like bladder symptoms, hot flashes, night sweats. It does help prevent osteoporosis, at least for the time that you're on it. This part is actually something I'm going to spend a little more time on. It does lower your risk of cardiovascular disease, assuming that you're taking it within 10 years of menopause or below age 60. The timing here is very important. And then it also has been shown to reduce the risk of developing diabetes. It also does help with some of those other symptoms, like we see that people who are on menopausal hormonal therapy, assuming the dose is high enough, it also does prevent those changes in your cholesterol from happening. It does help mitigate some of the weight gain that happens. It does help to impact all of those factors. However, menopausal hormonal therapy does still have a black box warning on it. The black box warning is for all hormone products. It is even on the topical products, the ones that are just for vaginal estrogen. And the reason that this black box warning is there is because there was a very large study called the Women's Health Initiative. This study, the average age of women in it was 63 years old. On average, they were 15 years after menopause. And in the study, they were taking a different format of hormone replacement that is prescribed today at a relatively high level. It was a pill. It was derived from horse urine. And the study was stopped early. And the reason it was stopped early was because they saw an increased risk of heart attacks and strokes. The risk was very small, but the headlines around it were enormous. So instead of, basically what they showed is the headline showed the percentage increase rather than saying, you know, you start at a very low baseline and it's still a low level of risk. And so it basically prompted this black box warning. People have been trying to get this removed. Obviously, they haven't been successful. Now, in terms of the therapy, though, in terms of like the key things, is that all of the societies, whether it is the National Menopause Society or even the cardiovascular societies, they basically say this: for the majority of women that are symptomatic, the benefits of menopausal hormone therapy outweigh the risks, and that it has to be based on a very individualized prescribing. I'm going to talk a little bit more about like what we consider in terms of prescribing, and that you basically want to start it within 10 years of menopause. Actually, I think you want to start it in perimenopause, and that you want to start it as soon as you're symptomatic, essentially, because that way you're starting it before there are already changes in your cardiovascular system, and that is what makes it safest. And that we know now you want to use, if you can, transdermal products. Typically, most people are prescribing a patch, at least for the estrogen component, and that patch can be paired with micronized progesterone, which is a bioidentical progesterone. You can't take it if you have peanut allergy. You have to get that compounded. There's also creams, other things, but the FDA-approved one that's covered by insurance that most people go on is a patch. And that for people that have specific risk factors, for example, they've had breast cancer or they have a high risk of breast cancer, like a BRCA mutation, this is where, you know, we do worry about the risk of breast cancer with hormones, but vaginal estrogen can be used in those people, and that there's no data that vaginal estrogen increases the risk of breast cancer. And then in terms of those risks, so basically what we know about in terms of risks is that there are increased risks of stroke. The risk goes away when you stop taking it. I'm going to speak more specifically about that in a minute. There is an increased risk of blood clots, but that's particularly if you're taking estrogen by mouth. The risk is very, very low in people that are using a transdermal product. Uterine cancer, but that would be only if you were on estrogen without progesterone, which is not what people are prescribed. And then breast cancer. So what we see with breast cancer is that if you're on estrogen alone, the risk of breast cancer tends to go up very slightly after you've been on it for 7 years. I would say most people actually aren't on it for that many years. And then if you're on a combined product, it's after 3 to 5 years. And then specifically, so this is what most people are prescribed, estrogen and progesterone. So the low dose patches have minimal or no risk. That is assuming that you're within, say, age like 50 to 60 or within 10 years of menopause for most people. For heart disease, actually there's no increased risk if it's begun within 10 years of the onset of menopause. Some of the newer studies basically show that there's a decreased risk between 35 and 50% in cardiovascular disease for people that are prescribed menopausal hormone therapy early. And then, as I mentioned, breast cancer, it basically rises the longer that you're on it, and then stroke, minimal risk. I'm not going to cover this slide. I'm going to sort of just talk about one other thing to consider. So for people that are considering hormones, it takes a lot of trial and error to get it right. So you have to really be willing to have a couple of appointments with your provider to get it right. Particularly in the beginning, because you can have annoying side effects, irregular bleeding, spotting. So just you have to know that going in. And that the bleeding, you can end up with an endometrial biopsy, which no one loves, but it's part of like what can go into it. I'm going to skip this one about the cardiovascular risk, but if you want to ask me later, I'm happy to take questions. But basically here is like if you have very high risk of cardiovascular disease, if you have uncontrolled diabetes, if you're smoking, all of these things that raise the risk of blood clots, raise the risk of heart disease and stroke, this is where like maybe you're not the right person, or maybe we need to modify those risk factors before you start. Testosterone, this one is gaining a lot of attention in the media. I do think that even though there's no product that's approved for women in the US, for some people this actually is helpful to add in. And oftentimes what we use are just like the transdermal, the products that are approved for men, but at very, very low doses. And then in terms of like, what do I do? Where do I go? I didn't really talk at all about Ovia, but I think what's really helpful is if you're having symptoms that you think may be due to perimenopause, to basically track your cycle, see what's happening so that you can see if you're having that irregularity, because you're a much better advocate than just showing up at the doctor's and complaining of all your random symptoms. If you can actually say my periods have changed and this is how they've changed, then I think it helps to speed up the right diagnosis. And then in terms of people have a hard time finding the right providers, typically I would say there is a board certification for menopause, and to basically look on the menopause.org, and they have providers that are board certified. There are also popping up online providers that are covered by a lot of insurances. I have no association with this company, but MIDI is one that they can prescribe medication for you. There's other ones as well, which is a good option if you don't have anything local. And then that same website, menopause.org, they have great patient-facing information and provider-facing information too. I also recommend the Australian website, even though some of the things are not necessarily approved in the US, they are really dedicated to making sure that people are prescribed the right things, and they have amazing resources.
Thank you so much for all of that information. Very thorough, and we got a lot out of it, I'm sure. Let me skip ahead to where we are here. And now we will hear from Dr. Lauren Turtelot, Assistant Professor of Physical Therapy at Russell Sage College, licensed physical therapist, and NSCA certified strength and conditioning coach.
Oh, yeah? All right. I'm not very good with the computer, so that was what I was most nervous about. All right. So what are we going to be talking about in this segment? A couple things here. We are going to be talking about resistance training. So we are going to start with talking about the benefit of resistance training overall for female health. Then we'll discuss some of the current recommendations, what's out there as far as evidence for resistance training for women in the perimenopause and menopause phases. And we'll conclude shortly with, if you're interested in getting started, you've never participated before, what are some safe ways that you can get started with resistance and/or strength training? All right, so the musculoskeletal system is comprised of your 206 bones and your over 600 skeletal muscles. So as a result of normal aging, we lose muscle mass. So sarcopenia is age-related loss of muscle mass. And it's estimated that we lose anywhere between 3 to 8% of our muscle mass each decade after age 30. This number can increase to 5 to 10% each decade after age 50. So that occurs as a normal result of aging in both genders. So us women, we actually get hit twice. So estrogen has a role in force production and muscle contraction. So as a result of declining estrogen levels, we also have decreased strength, muscle mass, decreased bone density, and an increase in adipose tissue, or that was the fat tissue. Not only an increase, but also we have that estrogen is protective for what we call visceral fats or adipose. So younger women, as talked about before, carry more weight in their lower bodies. That adipose tissue shifts into the midsection, which puts us more at risk for metabolic diseases such as type 2 diabetes. So we are losing muscle mass, lean tissue, and the only way to combat that is to meet it head on, and that is to build muscle tissue or lean muscle mass. So how do we do that? We do that through resistance training. So what is resistance training? It is a mode of exercise or physical activity where we use an external force. Oftentimes, this would be weights. Through that, we gain strength. So we think of that as how strong we are. So if we participate in strength training, we may be able to lift something heavier. We can also gain power. So there's a speed component to that. And hypertrophy. So hypertrophy is actually growing the muscle at the cellular level. So through lifting things that are heavy, so we have a high mechanical force. We create micro tears at the muscle level, and through protein synthesis, the muscle regenerates and actually gets larger, and that is how we increase our lean tissue. So there's good evidence to support that resistance training increases lean body mass, strength, functional capacity, so our ability to do our day-to-day tasks, confidence, overall mental health and well-being, so we get those endorphins, you know, those feel-good hormones, like when we go home and maybe like see our pet after a long day. Resistance training is a mode of physical activity, and physical activity in general has a favorable risk-to-benefit ratio, meaning greater benefit to participation than risk, and a favorable cost-to-benefit ratio, so especially compared to other medical interventions. And it is cited in the literature that physical activity is the most underutilized medical intervention in our healthcare system. All right, so what are some benefits overall for healthy female aging? Well, we just talked about how we're losing muscle mass, we're losing lean tissue, so benefits to our musculoskeletal system. Individuals that are stronger have a reduced risk of falls and reduced fracture risk. Increasing our basal metabolic rate, or our BMR. So lean tissue burns more calories at rest and activity than fat. So for example, we could have two women, both weighing 150 pounds. One woman is 30% body fat. The other one is 25% body fat. The woman who is 25% body fat is going to burn more calories throughout the day than the woman who's 30% body fat. Therefore, she's going to need a higher caloric intake in order to maintain her weight. So simply put, the woman who is leaner can eat more. We're also going to increase our mental health and well-being, and again, decrease risk of type 2 diabetes, other metabolic diseases, and chronic diseases like cardiovascular risk by minimizing that visceral fat. And Dr. Salzman talked about those vasomotor symptoms. So studies out there show that women who participate in routine resistance training report less vasomotor symptoms than women who do not. All right, so what does the evidence say? Like, what's out there right now? If you kind of read about women and resistance training in the perimenopause and menopause phase. Let me start by saying there's not a lot. But fortunately, in the last 5 years, there's been a little bit more attention brought to this topic. So I was able to pull some high-quality articles and studies. And there are studies out there looking at women from ages 40 to 80. The focus right now in the literature is on low-intensity and moderate intensity strength or resistance training. So how is that defined? We look at it from like a rep, how many reps we do a dosage. So for example, if a woman is prescribed in a study a low intensity resistance training program, they're looking at doing whatever particular exercise for 15 to 20 reps. So if you can imagine, if you can lift something 20 times, probably not too heavy. Moderate intensity, we're looking more at the 8 to 12 reps. So, okay, if you can only lift something about 8 times, obviously a little bit heavier. So the consensus is that moderate intensity resistance training does have a positive benefit for strength gains. So when they look at it, let's say with a 1 rep max, women who participate in moderate intensity resistance training can lift more than women who either don't or participate in low intensity resistance training. However, I do want to note that there is no evidence right now that moderate intensity actually increases lean body mass. There's also no consistent protocols or methods for resistance training. It's kind of all over the place. So some studies, women have a structured program, some they do not, some are a supervised program. So there's no formula out there of what is to best prescribe women for participating in resistance training. However, there's consistent reporting of decreased vasomotor symptoms, decrease in injury rate, and increase in quality of life. So those are all positive as well. The biggest gap right now is there is no studies around high intensity resistance training for women in this phase. So I first learned about Dr. Stacey Sims from my colleague, Dr. Hauser, and Dr. Sims is right now on the forefront for advocating for women's health, particularly for women kind of in this phase. Although what she talks about are true for principles of hypertrophy training across the lifespan, she really emphasizes this with women who are in the perimenopause and menopause phases. So before I kind of get to this point right here about lifting heavy, if you will, I just want to say this. If you're sitting here listening to this or you're watching on the stream and you're like, okay, you know, this girl up here kind of sounds like she knows what she's talking about. Please, please, please do not just go out and get a gym membership and start throwing barbells around, picking up things that are really heavy, because you can do a lot of damage by doing things wrong than any benefit you're going to get. So I'm a high school soccer coach, so anywheres, in summers I have anywhere from 8th grade all the way to high school seniors in the weight room, and we start them off before we lift anything heavy very gradually. They have to be able to do push-ups, assisted pull-ups, and we go through a squat progression. So you really want to learn how to do good body weight squats. Then I give them a dumbbell, we call them goblet squats, and they have to demonstrate that before we even put a bar on their back. So please consult with somebody who knows what they're doing and make sure that you're doing things properly because you don't want to have any injuries. Now, once you get more comfortable and you learn a little bit more and you get a little bit more advanced, you do want to progress to more of that heavy weightlifting. So you want to make sure that you're lifting weights where we're creating that stressor, right? We want to have those micro tears, and we want to be able to build that muscle through lifting heavy. So with declining estrogen levels as well as our age-related, loss of muscle mass, we are losing power and strength. So we want to make sure that we're lifting heavy, so we're recruiting more muscle fibers, we're having strong muscle contractions, and we're creating adaptions. How do we do this? Well, we do this by low reps. So Dr. Sims talks about working in that 5-rep range. So now, as you can imagine, if you can only lift something 5 times, it's going to be pretty heavy, much heavier. So you're going to do sets of 5, rest for a longer period of time. And in addition to building lean muscle through hypertrophy training, we're also going to get all those other added benefits as well that we would with moderate resistance training. All right, just a couple things just to kind of get you started. Push-ups are actually my favorite exercise, but one thing that drives me nuts in the strength and conditioning world is the knee push-up, or sometimes the girl push-up. I'm going to tell you right now, no good. When you are doing that, so you're doing a push-up on your knee, you're unweighting most of your body weight, you're not gaining any strength. So if you can't do a push-up, I'm going to tell you how you can learn to do one. This is exactly how I teach my soccer players how to do push-ups. You want to gradually build down from an incline. So let's just say a wall push-up is your highest incline. So if you can't do a push-up on the ground, start at an angle, maybe like a 45-degree angle. But here's what's really important. When you're doing the push-up, a lot of times you don't want to just be like bobbing your head, like you're like jamming to music. You want to make sure you're getting through the full range. Your chest should be touching the surface below you as you go through that. As you get stronger, you can bring that incline down, and then eventually you'll be able to do a push-up on the ground. Then when you get really good at it, you can work up the other way and put your feet up and do a decline push-up. A lot of gyms or fitness centers, they have the Cybex or the Smith machines. Often they're kind of in a nice little area of the gym. Those are nice because you're kind of working in one plane. You don't have to control your body weight. Much easier to use than using dumbbells or barbells. One thing I will tell you is if you do, pick up a heavy or try to push a heavy weight through that and you end up not being able to control it, you're going to kind of slam the plates and everyone's probably going to look at you. You're more at risk of that than getting hurt, so that's a good option. If you want to build some strength in your legs, squats are great exercises, but if you're not there yet where you're putting weight on the bar, while you're learning to do that, leg press is a good exercise to supplement for that. All right, so before I conclude, although primarily focusing on resistance training here, I just want to touch on a couple other key things out there. So studies show that there's increased benefits of adding cardiovascular training into resistance training, kind of doing both. So cardio, how is that done? A couple different ways. Continuous, that would mean, okay, I'm just going to go out for a run, so I'm going at a constant pace, or I'm cycling at a constant pace. Or high-intensity interval training, also known as HIIT training. That is where we are working really hard, and then we are resting and doing intervals. So you may be running, cycling, exerting at a really, really high pace, and then you're resting, perhaps walking for a short time, and then you do it again. And studies do show we burn more calories, we do burn more fat working in those extremes with high intensity. I consider myself pretty tough. I can lift a lot of weight, but I'm not tough enough to do yoga because I'm not flexible at all. But yoga has great benefits, especially in conjunction with resistance training. And the last piece I'm going to leave you to before I transition over is nutrition. So you can go to the gym, you can make a lot of positive gains, you can do a lot of good things. But one thing you can't do is you can't outwork the kitchen. So it's very important that we make sure that we're taking care of that. And so with that, I am going to introduce Dr. Sonia Hauser, who is going to come on up. Oh, hold on, I might have skipped ahead here. Oh, Associate Professor, Department Chair, and Graduate Program Director for Nutrition at Russell Sage College.
All right, thank you, Lauren, that was awesome. All right, I'm excited to spend the rest of our time together here talking about nutrition. So I just want to take a pause, though, and acknowledge that we've given you a lot of information today, and you probably have questions. And honestly, there's a lot more that we could talk about on these topics. We really had to rein ourselves in for the time. But we are, in the nutrition department, developing programming and additional resources, so I just want to make a plug for that. So stay tuned. But for the rest of our time here, I want to talk about statistics and the current nutrition guidance around menopause. talk about some exciting emerging science on the topic, and then end with some practical applications that you can go home and put into practice right away. So first, I want to start just level set again. So Dr. Saltzman showed a version of this slide. I think it bears repeating. So we have these three phases. We have premenopause, where we have this nice, beautiful EKG-like fluctuation every month in hormones. And then we have postmenopause, where we have lower levels of these hormones, but it's a steady state. And then in between, we have this perimenopause phase, right? So it's termed by some the zone of chaos. And you don't have to be a health expert to just look at this slide and see that this level of hormone fluctuation is just, it's going to have an impact on physiology, right? Some of you are looking in this and you're like, yep, that's me. That's, that's the phase I'm in. So just wanted to kind of remind ourselves of that. And what I'm sharing today covers both peri and postmenopause, but the sooner you can put these things into practice, the resistance training and the nutrition, the better off you're going to be metabolically in postmenopause phase. So looking at the statistics, so part of the marketing for this program was that there's just a lack of evidence. You heard from both of our speakers, there's a lack of evidence on this, it's under-researched, it's been kind of swept under the rug for a long time. So I want to put just some numbers to that lack of research. So I looked at the number of PubMed articles. So PubMed is this compendium of scientific research. So just to give a frame of reference, so cardiovascular disease, almost 2.3 million articles on this topic, which is appropriate. It's an important topic to look at. Heart disease is the #1 leading cause of death in the US. But contrast that with menopause. So you have less than 100,000 articles on this topic. And then moving on to, and you might say, well, that's kind of a false comparison, right? Because, you know, cardiovascular disease affects both males and females, right? But I would counter that with 100% of women will go through menopause if they live long enough, right? And menopause is a risk factor for cardiovascular disease, right? These dropping hormones increase risk for cardiovascular disease. So moving on to perimenopause. So less than 6,500 articles published on this topic. And then narrowing down further, nutrition and perimenopause, 313 articles, right? Which in some ways makes my job easier preparing for this talk, right? So I was able to actually read, I think, every recent research article that's been published on this topic. That's rare. So collectively, on this, in this phase of life, there's about a little over 100,000 research articles that have been published. So contrast that with pregnancy, fertility, childbirth, 1.5 million. So, which is appropriate. These are very important topics to research as well. But I will just, you know, think about the fertility window is a finite period in a woman's life, right? Whereas this peri and postmenopause period can be up to 40% of a woman's life, and less than 10% of the research attention paid to this phase of life. So there is some good news. The trajectory of research, as was mentioned, is encouraging. So this is nutrition and perimenopause specifically. So you can see that tall bar there. That's the 2024 number of articles that were published. Hopefully we will finish 2025 strong as well. So that is encouraging. What is less encouraging is the most recent article that was published on this topic, but you have to stay tuned till the end. I will talk about that in a bit. Okay, so that is the research, that's the science. But I wanted to look at what's the kind of social media? What are influencers saying, right? So say just hypothetically, but I was a woman in perimenopause, and I wanted to get some advice, right? I wanted to get to some advice on physical activity, nutrition, what should I be doing in this phase? So did a deep dive into what the influencers are saying. Some of you are laughing already. Okay, so there's a lot on macronutrient manipulations, right? A lot on probiotics, symbiotics, prebiotics, postbiotics, right? A lot of the gut microbiome. A lot of intermittent fasting advice. A lot of caloric deficit, so weight gain is a common complaint in this phase of life, right? So caloric deficit, but then an equal amount on beware low energy availability, right? So if you go too low with your calories, it's gonna spike your cortisol, you're gonna put on belly fat, right? So there's this tension in the social media around that topic. But by far the loudest messaging from social media was around protein. Yep. So for listening to what the influencers are telling me in particular to do, I came away with I need about 135 to 165 grams of protein per day, which is around 2.5 grams per kilogram. So kind of remember that number. Okay, so I'm going to unpack this, but just for context, so this is a graphic representing the acceptable macronutrient distribution ranges, right? So carbohydrates, fats, and protein. This was first published by the Institute of Medicine in 2002, has not changed since then. So I just will show this graphic so that we have the visual of there's no such thing, right, as just a high protein diet. So by definition, if you're increasing your protein, you have to decrease another macronutrient, right? So it either becomes a low-fat diet or a low-carbohydrate diet. So just putting that out there for a visual. So what are the recommendations currently? So for any adult woman, so this is perimenopause, premenopause, menopause, the recommendation is 46 grams of protein per day. A little bit different than what the influencers are telling me. So that equates to about 0.8 grams per kilogram per day. So this is very controversial among influencers who talk about how, the nutritionists are under-proteining everyone. So just want to point out, though, that the AMDRs are also, line above it, right? So these dietary guidelines issued by the USDA, Department of Health and Human Services, updated every 5 years, is both a target grams and a range. So those AMDRs are still there. The 46 grams is based on nitrogen balance studies on sedentary individuals. So this is to prevent protein deficiency, and it's the low end of that AMDR range, that 10%. So we're acknowledging with our guidelines that there is a range that would be appropriate for different people. So I'm going to talk a little bit more about that, but I also, before I leave this slide, want to just also highlight the fiber recommendations. So around 22 to 25 grams per day is the recommendation for this age group. So why so much emphasis on protein? Protein everywhere. Protein is important in this phase. So Dr. Turtelette set me up pretty well talking about sarcopenia. So age-related loss of muscle. This loss of muscle is accelerated with these hormone changes, right? So some of you have probably seen this slide before. It's a pretty famous slide. So these are two cross-sections of two different women's thighs. So the left is a 20-year-old woman. The right is a 64-year-old woman. And the dark tissue is muscle, and the light tissue is fat. So you can see there's a really dramatic difference. But the circumference of each of those thighs is roughly the same, right? So you can have not a lot of changes in weight and have dramatic changes in body composition during this phase. So body composition is really what we're concerned about here. The other really important thing to know from a nutrition standpoint about protein is anabolic resistance. So what does that mean? That means as we get older, it takes a higher level of protein to stimulate the same level of muscle protein synthesis. So if we're doing all the exercises, we need more protein to support muscle synthesis. So that 64-year-old woman would potentially need about 40% more protein than the 20-year-old woman to stimulate the same level of muscle protein synthesis based on age. So protein is important, but do we need 2.5 grams per kilogram? So there's a lot of research that shows that high protein diets are associated with higher risk of cancer, higher risk of cardiovascular disease, osteoporosis. A lot of evidence pointing to lower gut health, so gut microbiome disruptions with high protein diets. But if you dig deeper into these studies, it's typically people who are high protein from animal sources, right? So if you look at high plant protein diets, it's typically protective of all of these chronic diseases. The other thing about protein, it is very dependent on activity level. So for a sedentary individual, they need much less protein than someone who is very active, particularly doing resistance training. So there's a lot of studies on this topic. I want to just show you one in particular. It was an interesting study looking at, it was over 3,000 British twins. And it wasn't specifically a menopause study, but 89% of participants were female, and the average age was 72. So by default, it was a menopause study. So they wanted to look at what are the associations of low muscle strength and sarcopenia. What's predictive of this? So they looked at a lot of things. I'm just going to point out the protein one. So you can see higher levels of protein were associated with higher levels of sarcopenia, which is a little bit counterintuitive, right? So they used a reference range of 1 to 1.3 grams per kilogram. That was the reference. So anyone higher than 1.3 grams per kilogram had actually higher risk of sarcopenia. No association with muscle strength in this study. So a lot of studies kind of point to this 1.3 grams per kilogram as sort of the not too much above that for the average person. So a lot to, associations with chronic disease and in protein, but I think the most important point to point out here with high protein diets, particularly with high animal protein diets, is the impact on gut health. If it were up to me, this entire talk would have been about gut health, because I think that's where the bulk of the evidence in this area is really moving, but the influencers made me talk about protein. So transitioning to gut health. So we have premenopause, estrogen, progesterone, they drive this amazing gut diversity. So we have particular gut microbes, highly diverse gut microbes. That leads to healthy mucus layers in the intestine, nice tight junctions between the epithelial cells and the intestines, which is ideal. As those hormone levels drop, you see a commensurate drop in the diversity in the gut microbes, and you see an increase in the types of gut microbes that are associated with obesity, particularly visceral fat and chronic disease. So these dramatic changes are associated with those hormone changes. And you also have these tight junctions between those gut epithelial cells become a little bit loose. You have things like leaky gut. What you also have, which is really interesting, is you have a lower estrobolome potential. So what is that? Okay, so estrogen is produced in the ovaries, right, and in some other tissues in the body in lower levels, circulates throughout the body. As Dr. Saltzman pointed out, there are estrogen receptors all over the body, right? So estrogen circulates, it is then metabolized by the liver, and then sent into the GI tract through bile for excretion. So it can be packaged up, estrogen is bound, packaged up, and can be excreted, so it's gone. Or there are some gut microbes that can unbind that estrogen and send it back into circulation, thus increasing levels of estrogen. So fluctuating hormone levels impact the gut microbiome. The gut microbiome impacts the level of fluctuating hormones, right? So it's a symbiotic relationship there. So what happens when that relationship is interrupted in this perimenopause phase when we see those declining hormones, those fluctuating hormones? Well, this is happening directly in the causal pathway of those body composition changes we talked about are changes in the gut microbiome. There was one really interesting study I looked at that showed that gut metabolites could be predictive of sarcopenia levels, which is really fascinating. We also see disruptions in glucose and lipid homeostasis. So we have women who, we're going to hear from in a second, women who never before had problems with blood glucose control, never had high cholesterol. Suddenly, seemingly overnight, they have insulin resistance and they have high cholesterol and they haven't changed anything in their lifestyle, right? They're doing all the same things that have always worked and suddenly they're not working anymore. Again, in the causal pathway there to those changes are those changes in the gut microbiome. Mental health changes. Right, so we see mental health, mood disruptions, brain fog that Dr. Saltzman talked about, the gut-brain axis, right? So those microbial changes have been linked to those changes in brain function. And then we have just chronic inflammation too. So that translocation of that bacteria when those epithelial cell junctures in the intestine become a little bit loose. We have that translocation of bacteria, which can cause, it's termed inflammopause, right? So this is chronic systemic inflammation, which we know is underlying every single chronic disease. You look at chronic disease, there's inflammation happening. So what do we do about it? There are things we can do about it. This has been very kind of like a downer to some degree, but there are things we can do about it. So prebiotics, you've heard that term a lot. It's just a fancy word for fiber. So we need to increase our fiber. So 14 grams per 1,000 calories, roughly, but probably more important is the diversity of the fiber. So not just, I'm gonna have some broccoli and I'm gonna have some apples every single day, and that's my fiber, right? You need to mix it up, like more exposure to different types of whole food plant fibers has a real dramatic and positive impact on the gut microbiome. Probiotics from fermented and cultured foods can help this as well, and then adequate protein. So for the average person, 1 to 1.3 grams per kilogram based on the latest data. If you're going to start Dr. Turtelot's exercise resistance training, heavy resistance training routine, and doing your HIIT sessions, maybe bump that up to 1.8 to 2 grams per kilogram, but maybe mostly from plant sources to make sure that we're not increasing that risk of the chronic disease. So what does this look like? So this is not an exhaustive list, but I know you want examples, right? Because the key is diversity. So you want to have things that are not on this list as well, right? So I wanted to show this list, so prebiotics, probiotics, resistant starches, which can act as prebiotics. But the little asterisks above some of these examples is that they also contain an appreciable amount of protein, right? So you can get your protein, you can get your prebiotic fibers, you can get your probiotics in the same package in these whole food sources. So some examples. I see you taking pictures. We can send these examples out if you'd like. Even more practical. So here are 2 plates. Let's compare plates. So on the left, you have a plate full of plant protein sources. On the right, you have the classic perimenopausal woman's lunch, right? We're trying to get more protein, chicken breasts on repeat, right? It's an efficient source of protein. Nothing wrong with chicken breasts at all, but just want to make this comparison, right? So on the left, we have 576 calories, 54 grams of protein, 16 grams of fiber. So more than half of your protein and fiber for the day on just that one plate. And it's colorful and it's beautiful and it's delicious, right? And on the right, we have 400 calories, 39 grams of protein, and only 2 grams of fiber, right? So just kind of underscoring that you can get enough protein. There's a lot of controversy around this, I know. You can get enough protein from plant sources. You don't have to have a vegan diet, right? You can have a varied diet, and all foods can fit and can get you to that protein goal. Okay, so just practical application. Just want to finish with this. So consume a wide variety of unprocessed plant foods daily. Consume adequate protein from varied sources. And other things that I don't have time to go into that really bear mention is that consumption of omega-3 fatty acid-rich foods, so fatty fish, flaxseed, nuts, for that anti-inflammatory effect. Reducing or eliminating alcohol. Every symptom of menopause and perimenopause is made worse with alcohol consumption. Sorry to be the bearer of bad news. It is also not a friend to your gut microbiome, so reducing alcohol consumption. Consider vitamin D supplementation. Many women can benefit from vitamin D supplementation. And less level of evidence behind them, but some intriguing emerging research looking at artificial sweeteners. So reducing them for the impact on the gut microbiome, and then limiting antimicrobial food preservatives as well. And really, if you're having artificial sweeteners and food preservatives, those are markers of processed food anyway. So if we're shifting to a whole food, unprocessed diet primarily, actually you don't have to probably worry about those things. So in summary, so the majority of women suffer from menopause transition symptoms. A subset of that is severe symptoms that can be debilitating. Perimenopause can potentially start in mid-30s and can last up to 10 years. And then as we heard, postmenopause symptoms may continue up to 10 years, so this can be a very long time period in a woman's life. But these symptoms are highly influenced by lifestyle. So physical activity habits, nutrition habits can have a beneficial effect. There is something you can do. I always like to say I'm not fighting aging per se, but we're in serious negotiations. And it will be on my terms. So there are things you can do. Okay, so you stayed with me till the end, thank you. So now I'm going to talk about that study that I referenced earlier. So this is hot off the presses. This was an interesting study. It looked at sort of an overview of puberty through menopause, what our women's nutritional needs are. Great study. They mentioned some of the things I talked about in this talk, but what really struck me was the graphic they used. So we have puberty, pregnancy, lactation, and then right after lactation, we apparently become golden girls. So I am in this phase. I do not relate to this graphic. I'm glad you're having the same reaction. This is very validating to me, the same reaction that I did. So I think we really need to change the conversation around the topic of menopause. The first thing we need to do is talk about it, so check, I'm glad we're having this conversation today. But we need to sort of normalize this powerful resistance training, taking control of nutrition, right? And living this almost half of our life in a powerful and healthy way. And panel can come on up. I can think of no better way to start this conversation than to hear from our physical therapy alumni. You guys can come up. Debbie Berube. She is going to share, she's very brave, she's going to share some of her personal experiences with this menopause transition. She's sort of come out on the other side. She's lived to tell the tale, and she has a lot of great advice for us. She's given me a lot of great advice. So we're going to transition to Debbie. I do want to just put this up there. If you would be so kind as to, before you leave, just scan the code and take our survey. We would love some feedback for our future programming. Take it away.
Hi, everybody. So I'm really just here to kind of reinforce everything these wonderful women talked about today, and to also just let you know that you are not alone. I have been down this journey for about 5 years. It started for me with a 20-pound weight gain in a 3-month period. Nothing changed. I work out 6 days a week. I'm a pretty competitive athlete. I already do a lot of resistance training, and I couldn't figure out why I was gaining weight. Nothing ever changed. I was still eating a ton of protein a day, 130 to 150 grams of protein, and yet I was gaining weight. So, like everybody said here, I kind of went down that rabbit hole, started doing my Google searching, weight gain, what is going on? And it just led me down to all of the social media influencers and just led me into perimenopause. And I was like, oh my God, I actually am that age, which is really hard to believe because I don't feel that old. So the weight gain, the night sweats were horrendous. The anxiety was really bad. Depression, I was at one point, I was on 2 antidepressants, and I think I was on 3 anxiety meds, which is a lot. Other than feeling absolutely exhausted because the meds were so intense, I didn't feel any better. So for me, I needed something that was a little bit more natural for me. I didn't really enjoy being on a lot of medications. So that, of course, led me down the rabbit hole of bioidentical hormone replacement therapy. So I had to advocate for myself because I'm sure, like most of you, there's doctors that don't know how to prescribe it, that live near you, and you're just feeling helpless. So I started using an online portal for my medical needs, was able to get in touch with a really good clinician, and we started the process of patches and progesterone. And like they said too, it's constantly changing. I mean, I'm still 5 years in. I'm still trying to figure out what level of estrogen to be on and what level of progesterone to be on because it's constantly changing. I've tried the patches. For me, the patches weren't really absorbing into my skin well enough to increase my estrogen, so I did go to the fem ring that the doctor talked about. That's been a game changer for me, especially with the vasomotor symptoms, the night sweats. But all of those things are just constantly changing. It's still a process for me, but you're not alone, I promise you. And you just have to find that person that you can kind of connect with. Again, if it's an online portal, reach out to your friends. I think the other thing that was very important during this whole process is commiserating with my friends and being like, oh, you're experiencing that too? Oh, okay, I'm definitely not alone. And that has certainly helped with this journey as well because I really did think I was going crazy a few times here and there. So that's really pretty much been my journey, so.
And Debbie and I bonded over the eye changes.
Oh, and dry eyes? Like my eyeballs stick to my eyelids. Like it's all the time. It's terrible. I mean, all 35 symptoms, I think I've probably got 34. But yeah, it's compounding, and it affects your mental health because you don't feel good. And when you're used to feeling really good, you know, it's
you don't
really,
feel good, and then
you don't feel
you're
good.
not taken seriously.
Right, and then you're
by
not taken
some
seriously.
clinicians.
Correct.
Yeah.
Right.
Yeah.
And then to just and again to constantly be prescribed meds for the symptoms, which sorry, I did not know that was on. It was just frustrating. I didn't want to be on a lot of those meds, and you know they just don't always make you feel great either. So if I could switch to something that was more natural, that certainly worked better for me. And I'm off all those meds, which has been so lovely too. So
yeah, great. So we are at time, but we would love to take maybe a couple of questions from the audience. Sorry, we're over time. We get excited talking about this topic, all of us.
I could talk all day.
Anyone have any questions? We're grabbing the mics.
Going through these symptoms? Can it,
Oh.
you know, when you talk about these symptoms,
Right.
you end up
Depression,
in mental
anxiety.
health sometimes. So could that be a false mental health diagnosis?
Anxiety and depression, definitely. I mean, it happens all the time. That people, I think that your story of, you know, they go to the doctor and they say, I feel terrible, I'm anxious, I can't sleep.
Yeah.
It's always like you have anxiety rather than like treating the hormonal disturbances that are underlying it. And the hard part too is like the most common, it's an SSRI, a selective serotonin reuptake inhibitor is usually what's prescribed first. And that causes decreased libido, it causes nausea, it causes headaches. So for a lot of people, and I'm not saying that's not the right treatment sometimes, but it causes other symptoms, and it doesn't relieve it may not relieve the other symptoms that you originally were concerned about.
Yes, and the mental health meds, they don't make you put on the weight themselves.
That's exactly right. That is a very common side effect is weight gain. So it makes it worse.
So the best way to get out of that spiral is to talk to my regular doctor and ask him for a good,
The Menopause Society does also, if you go on their website, there's a list of local providers who are menopause informed, and so you can find a good doctor that way.
I don't think this is a really quick question, so maybe it's not a great one, but one of the things that you were talking about was portals and apps and things like that. And in this era where data and privacy is at risk and seems to be a free-for-all, are there other management tools or research tools that you might recommend that don't involve putting all of your data in, just getting information back out?
I mean, you can go ahead and track like your cycle, for example, on a paper calendar, or just on your own phone. I mean, you don't have to use some other tool if you don't feel comfortable sharing that information. I think the portal part was more about, there's telemedicine only providers that are geared towards menopause. I actually don't think that you have a lot of risk in terms of sharing information there. I mean, you're covered by HIPAA. I don't think there's a lot of risk for most patients getting care that way.
I have a comment more than a question, but just thank you for this very practical topic today. And I also feel strongly it's important that not only do we educate ourselves as women, but our spouses and males. I
Absolutely.
raised 3 sons, and they thought I was really going crazy during menopause, and they're married now, and I want them to know this is normal, and and they need to be educated in terms of a lot of changes that occur.
Yeah. I have 2 boys, they're 23 and 24, and they're very versed in my perimenopause journey, and which I think is fantastic because, like you said, I think it's going to help them, in whatever relationships they, create. But they know. I've informed them of everything.
And bravo to the men in the room right now.
Yeah.
Anyone else? Okay.
Is there anything
Microphone.
that shows?
Microphone.
Okay. Is there anything that shows the onset of menstruation related to when you begin perimenopause? And are we going to see if there is a younger age of menopause since we are seeing a younger age of menstruation?
Possibly, yes.
That's a good question.
Because there's data that shows that when you start menstruating earlier, you go into menopause earlier. So yes.
I don't know if there's enough studies yet, but are we seeing anything where there seems to be an increase in fertility treatments and IVF? Is there any indication or thoughts around how that could potentially affect maybe onset of perimenopause or symptoms or things like that?
I don't think we know yet, unfortunately.
Anyone else want to have the last question? Oh, okay.
Do you have any suggestions on the best way for a woman to go about finding a doctor that would be a good fit for them? It's obviously we can't interview or have a little consultation before we actually sit down for that one preventative appointment that our insurance will pay per year. So I don't know, are there ways to find a good doctor that the person would fit with?
Well, this is where I say, I mean, and I don't say it because I've actually done the training, but I do think that that Menopause Society is quite good because the exam's really hard. Like, you really have to know a lot in order to get that certification. But what I would actually say is I do not recommend that you have this as part of your preventive visit. It is, the doctor has like all these things to go through for that preventive visit, you know, your vaccines, your mammogram, colonoscopy, family history, and this is a long conversation. So schedule another visit. I know it's a copay, but I would actually say, like, you need 20 minutes at least to talk just about this because the treatment is so individualized and so specialized, so you can't really cram it in. Same with, and some people, I would also say, if you have a gynecologist, ask your gynecologist. Most gynecologists should be able to do this, but don't do it at your annual GYN visit either. There's not enough time to address your needs.
Yeah. Agree. I feel like this is the 13th annual nutrition lecture. Every year we end with policy. We need policy changes. And so very encouraging, just yesterday, California, the state of California, pushed through advanced legislation to promote coverage of doctor visits for menopause symptoms. Right now it's not covered, right, which is crazy, right? Like these metabolic changes that are happening are not covered. Our own New York State Senator Gillibrand also about almost a year ago was also advocating for federal level legislation around menopause research. So funding research in this area and increases in coverage. And I think that's where we need to go. There's increasing awareness at our level, but there's only so much we can do, and only so much providers can do. We do need policy change around this. It always ends up with policy. Anyone else? No, we're good. Okay, thank you so much, everyone. Please take the survey. Thank you for coming.